As you know, cardiogenic shock is a very tough substrate to treat. Nearly 50% of these patients, unfortunately, never make it out of the hospital. So, in such patients, despite all the advances that we made in cardiovascular medicine with therapeutics and diagnostics, there is always a challenge of identifying improvements in care processes and healthcare delivery for these patients, which may contribute to improvement in outcome. Hello, everybody. My name is Dr. Saraschandra Vallabhajosila. I'm an interventional and a critical care cardiologist at Rhode Island Hospital, Brown University in Rhode Island. I'm here delighted to share our article titled The Need for High-Dose Pharmacological Circulatory Support in Cardiogenic Shock that is going to be published in the July issue of the Mayo Clinic Proceedings. This was a perspective piece that I wrote with a couple of my colleagues, like-minded colleagues who are very interested in the cardiogenic shock space. One of the issues that I've seen in my practice, and I'm sure other colleagues have too, is the understanding of pharmacological support in these patients. So for background, I'm an interventional and a critical care cardiologist. So I work in the cardiac ICU and in the cardiac cath lab caring for these patients. So often I'm present caring for them at their sickest when they present to the hospital. So what I've seen is these patients often come in with varying medications such as norepinephrine, dopamine, dobutamine, epinephrine, vasopressin, phenylephrine, all of which are used to augment the blood pressure, the inotropy, and contractility in various ways. Unfortunately, there is not a very good way to summate all this information, and we tend to be very cut and dry about how we measure these medications. On the flip side, in the critical care space, we have seen that these patients have very specific ways of being measured for populations such as septic shock or post-cardiotomy vasoplegic shock and such. So I said, something similar can be very applicable in patients with cardiogenic shock too. So in this opinion piece, again, it's an opinion piece. It's backed by some indirect data, but obviously is more about laying the ground for future work in this field from colleagues across the country and the world, trying to understand this better. What we hypothesized was it's very important to summate all the vasopressors that patients are on, and then use that information to define significant thresholds of high-dose vasopressors. Well, why is that important? Because high-dose vasopressors, which can be defined by various cutoffs, can tell us when to stop doing the same and try to think of a different strategy. How to define refractory shock. When can we use pharmacological adjuncts or mechanical adjuncts in cardiogenic shock? We are blessed with a gamut of devices that will help us understand when to insert these devices. And then, unfortunately, in some patients, it may also help us define futility. Is if when too much of these vasoactive medications are associated with bad outcomes, and if you say that beyond a certain threshold, about 80% of patients don't make it alive out of the hospital or have a meaningful recovery, then that may give us an important piece of information to have a conversation with patients and their families. So in this particular opinion piece, we said it's very crucial that we define the extent of the problem, define what the high-dose vasopressors are, proposed examples of how to do it in clinical practice, highlighted why it's important, and therefore said how we can use this information to move the needle in patients with cardiogenic shock, constitute the sickest spectrum of patients we see in the cardiac ICU. I hope you find this read helpful. I hope you find this read thought-provoking, and I would love to see more literature from colleagues across the country and the world on this aspect. Thank you for your listening. Thank you for your time. Please email me if you have any questions.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings. Our journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.